Good evening, good evening, good evening. Thank you for joining us, or good morning or good afternoon, whatever time of day you watch this viewing. I am Dr. Charmaine Green, and I'm the director of the Center to Eliminate Cancer Disparities at the Sidney Kimmel Comprehensive Cancer Center at Jefferson. It's my honor to welcome you here to join this Facebook Live event that is part of our conversation about cancer, talking about recovery, research, and reducing your risk. Our topic for this evening, for today, is multiple myeloma, and we will cover information on symptoms, diagnosis, treatment, research, and resources. Today we are joined by medical experts from Sidney Kimmel Comprehensive Cancer Center, and we also have a special guest. As we progress through this program, please do not hesitate to ask questions. You can place your questions in the chat, and we will do our best to take care of your questions during our Q&A portion of the program. So to begin our program this evening, I'm going to ask if our panelists can briefly introduce yourself. Today we have with us Dr. Adam Binder, Dr. Amy McKenzie, Mrs. Jody Santos, and our special guest, Ms. Dana Allen. Dr. Binder, can you give us a brief introduction?
Yeah, hi. Thank you for having me tonight. My name is Adam Binder. I'm one of the medical oncologists at Thomas Jefferson University in the Sidney Kimmel Comprehensive Cancer Center. I am a multiple myeloma specialist and run the myeloma program and plasma cell disorder program at Thomas Jefferson University. Thanks.
Thank you. Next, we have Dr. Amy McKenzie. Can you introduce yourself?
Sure. I'm Amy McKenzie. I also work for the Sidney Kimmel Comprehensive Cancer Center. I'm in Willow Grove at our Asplund Cancer Center. My specialty is geriatric oncology, and so I treat a variety of cancers, but I treat a lot of myeloma in my older patients, and I'm very happy to be here.
Thank you. Thank you. And Ms. Jody Santos, can you introduce yourself, please?
Sure. Hi, I'm Jody Santos. I'm a licensed clinical social worker at the Sidney Kimmel Cancer Center. I'm the program manager for the heme malignancy and bone marrow transplant service here in Center City. And my role is really to work alongside our patients and families to help address a lot of the changes that come along with the multiple myeloma diagnosis, whether that's for emotional support, resources, and work closely with the care teams to really address the needs of our patients.
Thank you. Thank you. And our special guest for today, Ms. Dana Allen. Please introduce yourself.
Good afternoon, everyone. I am Dana Allen. I was diagnosed with multiple myeloma November 2021, and I have in this struggle, in this fight, along with my team up top there who has guided me, and we're on the right path. We're just going to keep going. Thank you for having me.
Thank you for being with us. So thank you to each of you for joining us today. So as we begin this conversation, I'm going to ask Dr. Amy McKenzie if you will discuss the diagnosis and treatment of multiple myeloma. Please share with us some things about what is multiple myeloma, how common is it, how is it diagnosed, what is the cause, if there is a cause of multiple myeloma, and if there are any particular tests that are done to diagnose. Dr. McKenzie.
Sure, I'd be happy to. Yeah, thank you so much. Multiple myeloma is a blood cancer. So you may have heard of other blood cancers like lymphoma or leukemia. Multiple myeloma does come from blood cells, from white blood cells. It's not very common, actually. It's only about 1 to 2% of cancers, and it's about maybe a little less than 20% of the blood cancers that we see. It's found more often, I would say, in older patients, maybe over 65. There are some people younger than 60 who get it. It's not common, and very, very rarely we see it in patients who are between, 35 and 40, but that's highly unusual. So most of the time, this is a disease of aging, as are most cancers, diseases of aging. So that's a little bit about, who gets it. It is more common in patients who are Black or of African-American descent, and more common in men than in women. There's a very, very slight connection with family history. Just because somebody in your family may have or have had multiple myeloma doesn't mean that you will get it. but it can sometimes be connected in families. It's not a disease that we screen for because that doesn't really change anything. So there's not a blood test or a CAT scan or anything like that that would help it to show up earlier. Usually what happens is either through a routine blood test, your doctor may identify something that's abnormal, and that may lead to further testing, and then you would end up with one of us, the hematologist. And there's a spectrum of diagnoses that lead to myeloma. There's a very early stage where you may have a little bit of an abnormal finding in your blood, but it's not a cancer, and it's something that we watch. Sometimes patients, will come to the office with something that's a little bit more advanced. And then when you develop active myeloma, that's when we start to talk about, what are the treatments that we can do. So the diagnoses, the diagnostic tests would be usually blood work, and we would want to take pictures of your bones because multiple myeloma can sometimes affect the bones. So that could be X-rays, a CAT scan, a PET scan, sometimes an MRI. And because this is a blood cancer, usually we do a bone marrow biopsy, which I think is scary for people, but we do them quickly. Sometimes patients could get a little sedation. It depends on where you are, but we carry you through that, so that there's minimal discomfort with that. So it's a battery of things that we do to help diagnose. And then if you develop a diagnosis of multiple myeloma, you'll have a care team. And fortunately now, there are so many great treatments for myeloma. We have progressed so much in the last 10 years. And so we have pills, we have IV, we have injections that go under the skin. And we really try to individualize your treatment, to what your health is like. You might end up undergoing a stem cell transplant, or you might end up getting other medications in the hospital. So it's a very individualized plan. And, many people can do very, very well with multiple myeloma for a long time. So it's always scary to get a diagnosis like this, but it doesn't mean that you can't live with this disease and be healthy and happy and active. Each person is different. So I think that's a good summary of, some of the basic things about multiple myeloma. It's a pretty complicated disease, but, if you have concerns about it, if your family member has it, we're here to answer those questions for you.
Now you mentioned something about early stage versus active myeloma.
Correct.
What would early be? What would be how would you diagnose, or what would you determine early?
Right. There's something that's called an MGUS, which is a short way of talking about something called a monoclonal gammopathy of undetermined significance, which is why we say MGUS, because it's a big mouthful. Essentially, what that means is you have an abnormal protein in your blood that may or may not progress to multiple myeloma. The risk of progression of this is low. It's about 1% per year. And many patients over the age of 65 have this, and it never turns into anything. So you could essentially call that a precancer state, but it rarely becomes active multiple myeloma that requires treatment. And then there's a phase in between the MGUS and the myeloma that's called smoldering myeloma. And it's basically our way of categorizing patients with certain criteria about how many, abnormal cells you have in your bone marrow and et cetera. And we're looking more into, starting early treatment for those patients. And I'm sure Dr. Binder might talk about some of that. There was one other thing that I was thinking of talking about, and it slipped my mind, but the idea, I wanted to talk about things you can do to be healthy. So one thing that we know about multiple myeloma is that being overweight or being obese can increase your risk for this. So anything you can do to be healthy and try to maintain a good weight is really beneficial for you. So, that's a good thing for any disease, but we do know that that is associated with the development of multiple myeloma. People who've been exposed to Agent Orange can have an increased risk of developing multiple myeloma. Other than that, there's not a lot that's convincing in terms of what really affects you. Of course, we always want people to not smoke, limit their alcohol, try to exercise. But in terms of looking at actual real associations, obesity is probably the only one that comes up again and again. So if you want to try to be healthy, those are the things that I would recommend in terms of, trying to take care of yourself and avoid things. Sometimes it's not avoidable and it's not your fault. People just get diseases. But the important thing is to make sure that you're following up, with your doctor if something's abnormal. There's no screening test for this, so you don't have to worry about that. It's not like a colonoscopy or a mammogram. But routine healthcare is really the way to go.
Now, you mentioned Agent Orange. I know there are some cancers where individuals exposed to particular environmental things can cause those particular cancers. Is there anything that can be identified within the environment which may lead to an individual developing multiple myeloma?
To my knowledge, we haven't identified anything concrete. And Dr. Binder may know of other things, but in terms of environmental exposures, you hear about asbestos, being associated with certain types of lung cancer. There isn't a particular chemical or exposure that we have definitively linked to myeloma at this time.
Okay. Thank you so much for sharing. Thank you, Dr. McKenzie.
Yes, you're welcome. I'm happy to answer any other questions.
Sure. Well, as we go along, I'm sure something will come up. Next, we have Dr. Adam Bender. So, Dr. Bender, can you please talk about your research in multiple myeloma and some of the findings that you have identified or findings that have been found in your research?
Sure. Yeah, thanks. So before I go into that, I'll just to add on to what Dr. McKenzie was just talking about in terms of environmental risk. I agree. There's not a lot of sort of clear pollutants that maybe increase your risk, but we do know that certain things that you breathe in or certain pollutants in the air can increase your risk for myeloma along with other cancers. A lot of the first responders at the 9/11 World Trade Center site have an increased risk of cancer in general, but multiple myeloma was one of them, and it's thought to be, probably because of some of the pollutants in the air that they were inhaling. There was a study that came out of Montefiore Medical Center in the Bronx. Actually, it was published by one of the faculty members who are now at Jefferson, also showing that in the Bronx, looking at where you lived, how close you were to one of the highways and how much of the pollutants you were getting from the exhaust from cars actually also increased your risk for plasma cell problems, which are something along that spectrum that Dr. McKenzie was talking about, MGUS or smoldering myeloma or multiple myeloma. And so there does seem to be some association or relationship between pollutants and this risk. We actually submitted a grant by one of the trainees here at Jefferson to try to look at something similar in the Philadelphia area to try to better understand, are there certain neighborhoods within the Philadelphia region, are there certain risk factors in the environment that actually can increase your risk of developing some of these plasma cell disorders like MGUS or smoldering myeloma and multiple myeloma. And so I think that, kind of goes really nicely into the importance of research in general, for patients with cancer and just understanding cancer risk. Everything that we know about multiple myeloma and all the great advances that we have and all these wonderful new medicines that have been developed really over the last 20 years have occurred because of research that, individuals have done in the past. And all those participants, patients with myeloma, who were interested in participating in that research. None of this advancement could have happened without the participation of people, people who are, willing to, enroll in these studies and, hopefully benefit themselves, but also, provide valuable information for the future and for everybody else. When thinking about, individuals with myeloma and thinking about disparities, this, as Dr. McKenzie said, this is a cancer that affects people who are older. We often say that what we call the median age, meaning 50% of people are younger than this age and 50% of people are older when they get diagnosed, is somewhere between 65 and 71. So African Americans or people who identify as Black are generally younger when they get diagnosed with myeloma, but Caucasians and other races are a little bit older. The other thing we know, as Dr. McKenzie also said, is that people who identify as Black or African American are twice as likely to get multiple myeloma, and they're actually more likely to die from it as well. And there have been some studies looking at that, trying to understand, is it something about the myeloma itself, or is it something more around access to care? And actually, it's more around disparities in access to care that leads to this difference in death, to be honest. When they look at access in terms of people getting to treatment at the same time, people getting the same intensive therapies, and the last thing which we're talking about now is access to clinical trials and people having access to clinical trials, we see that all individuals do the same. So, there's no difference in the biology of the cancer based on your race or your gender. It's more just about your access to high quality care, access to novel, like new medications, and access to clinical trials and clinical research. And all of that is really important to, kind of improving, how people live their lives and how people do. In terms of the type of research that I do, I have sort of two main focuses in my research. Some of my research is in developing clinical trials for people with multiple myeloma and trying to use new medications that work in different ways, a little bit differently than what we have available, to see if they work better than what is available, or combining them with medicines that we have now to see if we can, get the responses better, get more people into remission and help them live longer. I also do a lot of research around healthcare delivery and not only like what medicine do you get, but how do you get it and where do you get it? And I'm very interested in bringing care to individuals, making care easier, more affordable, and less burdensome. Anybody who's has myeloma or has a loved one with myeloma knows that the burden of treatment is very high. You're coming in very frequently for visits. You're traveling a lot. There's a lot of side effects to the therapies. And so I'm very interested in bringing that care to the home and have done clinical trials about bringing chemotherapy to the home to see if that, lessens the burden, decreases some of the financial toxicity and cost of care, that out-of-pocket cost, and in general, just improve overall quality of life. So kind of focusing on both of these areas, sort of looking at new medicines and how do they work and how could they improve the responses for someone with myeloma, but also how can we just make their life a little bit better.
You mentioned the clinical trials and work being done regarding trials, understanding that there is a disparity in individuals who develop multiple myeloma. Is there also, or are you seeing also a disparity in the individuals that participate in these clinical trials? And if you do see this disparity, what is being shown or what is being found?
Yeah, that's a great question. So there's definitely a very striking disparity there. I just told you that multiple myeloma is twice as common in African Americans, but if you look at large clinical trials for multiple myeloma, for most of them, maybe only 3 to 5% of the individuals enrolled in the trial are identified as Black or African American. So there's a huge underrepresentation in these clinical trials of the people who are actually getting multiple myeloma. And I think that's something that the research community is trying to do better about and recognize. I don't want to give Thomas Jefferson a pat on the back, but we do a lot better than that. So when we look at our multiple myeloma trials and how we do in enrolling individuals, about 40% of those who enroll on clinical trials for multiple myeloma identify as Black or African American. So our clinical trial enrollment is much more representative of the general myeloma population, but as a whole, the research that's being produced and the studies that are being done, individuals aren't being represented as much as we could. Some ways they're trying to fix that is a lot of these clinical trials are run by pharmaceutical companies, because there's their products, and they are, working really hard to open the trials at the right places, to bring the trials to communities of Black and African American individuals. So opening places at, I don't know the audience here, but somewhere like Montefiore Medical Center in the Bronx, where they're largely serving, Black and African American community. So it's just easier to enroll as opposed to maybe, not to be biased or anything, to some of the larger major cancer centers where their patient population is majority Caucasian. So I think they're doing a little bit better, but we have a long way to go.
Now, what would be the benefit to having more African Americans enrolled in clinical trials?
So I think that we, when it's similar to, we want to make sure that the results of the trial and the side effects that we're seeing and the outcomes that we're seeing are happening in those that are experiencing, that cancer or that disease or that burden. We can never say for sure. Everyone metabolizes medicines a little differently. Everyone responds to medicines a little bit differently. And so, we can't say for sure that if in this group of people the medicine works this way, it's definitely going to work this way in another group of people. It's similar why we want to have a balanced representation of men and women on clinical trials. Because if a drug works really well in men, we can't say 100% that it's going to be exactly the same in women. People just, metabolize things differently and respond to them a little bit differently. And so it's important that the trials have a population of people that are representative of the people in the real world that we're going to be giving the medicine to.
Thank you, thank you, thank you. Let's see. Trying to think if I had another question. Now, you mentioned something, but I'm going to take it to Jody. You mentioned something that I think would relate to Jody's conversation. So we're going to go to Jody, who is our social worker. And I'm going to ask you if you can share with us, begin with explaining what financial toxicity is. Dr. Bender mentioned it, but can you explain what that is and how does it apply to patients who are being treated for multiple myeloma?
Sure, thank you. That's a really good question. So what we do see that there is a large financial burden, toxicity for patients going through treatment for multiple myeloma. And that is really the financial burden that patients and families experience through the trajectory of their illness. What we do see a lot for multiple myeloma, which is a little bit different than maybe some other diagnosis, is sometimes the chronicity of the illness. Patients are often on treatment for extended periods of time, on multiple lines of therapy. And a lot of the patients are not able to work on decreased income, whether they're on disability or fixed income, so they're an older population on Social Security, with the added medical costs. And one thing we do know about multiple myeloma is a lot of the medications for multiple myeloma are extremely expensive. And so we're often trying to find copay assistance or foundation assistance through the pharmaceutical companies to help offset some of the costs. A lot of patients' bills were relative to when they were working, and now added medical expenses, transportation expenses, copays, multiple medical appointment copays. All of those expenses added to these fixed incomes really do impact patients financially. And so a role of the social worker is really trying to look at the whole person and seeing how we can maybe offset some of those costs and financial burden that patients and families experience. Oftentimes, also caregivers are losing time at work. to bring people to appointments. Some people don't have paid time off to bring people to appointments, so they're losing income in that way as well, if they might be the only one working in the household. So, as we try and look at community resources, oftentimes to make referrals, the difficult piece that I do find sometimes with multiple myeloma is due to the chronicity of the illness. A lot of community resources are one-time only grants, and so people could be on treatment for multiple years and you don't have as much access to some of the grants. So we're always trying to be creative and look at other ways to address the financial needs of our patients. So, and with the financial needs, what we're also seeing is the emotional distress that patients experience, right? So it's difficult enough, I think, having a diagnosis, going through treatment, managing the uncertainty of their illness, and then adding these financial stresses. How am I going to pay my rent? How am I going to provide food for my family? All of those things add to anxiety, depression, difficulty sleeping. So that's kind of where the social work role comes in, to try and really address those barriers to care. One thing I do have seen as well, some patients decide not to pick up their medication. They're trying to rationalize their medication due to these high copays. And so we really want to try and find other resources and ways for patients to pay for their medication so they can get the needed treatment for their myeloma. And,
Okay.
oh, sorry.
Go ahead. I'm sorry.
No, I was just going to say, and then, oftentimes, it's really trying to assess to see where patients are, and working with the care teams as well. Sometimes, people might not even be aware of some of the concerns. They might not be disclosing it. And as a social worker, we're trying to really kind of understand a little bit better of where they are and kind of communicating. Are there other medications that might be, that they might be able to use that are less costly? So. Financial burden, I think, is a big piece of people facing multiple myeloma.
Now, I know for some cancers, there are state-run programs that provide funding. Are there any such programs in the state of Pennsylvania, since that's where we are located, for multiple myeloma patients?
So I would say more for multiple myeloma versus statewide is sometimes the foundation assistance or copay assistance, like the Leukemia Lymphoma Society has a copay program. HealthWell has a copay program, same with Patient Access Network. So those are ones that we often try and get people connected with. They can sometimes help with insurance premium assistance, or there might be like a large copay grant available to help with the medication costs. But we are also trying to refer to state programs if people have loss of income, trying to get them on some state assistance as well.
In your role, do you have resources that you also provide to caregivers who are assisting patients that are experiencing multiple myeloma?
Yeah. So, I mean, we're fortunate here at Jefferson that we do have a lot of support programs available. In terms of caregivers, I mean, we try and address cancer as a family illness. Everyone is affected by cancer in different ways. For caregivers, we do also want to address their needs. So we do often meet with caregivers for counseling and support. We have a caregivers support group. But we also really try and meet with the caregivers to talk about, and especially with multiple myeloma, the endurance of being with a loved one over the course of time of their illness. So really needed to take time to take care of their own self-care, really trying to, stress the importance in order to sustain it over time, that caregivers really need to take care of themselves. Learning to ask and accept help is a big one. Sometimes, even just, transportation assistance that we help with, right? So caregivers can work and we can get patients to appointments, and trying to rationalize their time off from work is an important piece. But there are some online support groups that we also refer caregivers to, and really we address cancer as a family illness. So we really do want to also include the caregivers as part of that.
And what do you mean a family illness?
So everyone in the family is affected by a diagnosis, right? So the patients going through it, they're the ones who have the diagnosis, they're getting the treatment. Oftentimes the loved ones are also watching someone they love go through treatment. They're managing the uncertainty of their loved one's future as well, and what this means for them. They're also having financial toxicity as well, of like stress with trying to balance things at home with taking care of their loved one, but also taking care of the household and taking care of children, getting people to appointments and balancing a lot. So really, everyone is affected by the illness. So we always try and look at the whole person and whole family as we address a diagnosis. Sometimes the loved ones are the ones who are experiencing more distress than the patients. So we do meet for them for counseling as well.
Thank you. Thank you. Now, is there anything else that you feel is important to share right now as a social worker?
Yeah, so I think as a social worker, I mean, we work really hard, I think, as trying to be part of the care team with the doctors and nurses. I kind of see myself as the person between the patient and the care team. So patients will often come to me with a lot of sometimes medical questions that are out of my scope of practice, but often can, relay that to the team, and trying to really be that person that can really patients can come to, right? If someone's not getting back, where to go, help with the navigation of the healthcare system can be very overwhelming for patients. So we really try and ease that burden for patients and family members to know that they can also come to us, and we will communicate their needs or concerns. We also address sometimes things that are difficult to talk about, right? That they might not be sharing with their medical team, but they might share with us some of their social situations, some concerns about managing the uncertainty of their future, end of life care. So we try and also enhance care at home for patients, whether they need physical therapy, home care coming into the house, trying to really look at the whole picture to help them really maximize their quality of life. And I think that's kind of where we come in.
Yeah,
Thank
if I
you.
could, if
Go
I could
ahead.
add, I mean, I think that last piece is so important, and why it's so important to have a team working with you, not just a team at home and a family and social support team, but also a team at your cancer center, because there are a lot of reasons why people don't bring things up to me or Dr. McKenzie, and some of that reason is they don't say things because they worry it may interfere or may change the way I decide to treat them or give them certain medicines, and they don't want that to happen, and so they may bring it up with Jody or somebody else on my team. And if we didn't have a whole team, working with that individual, we may not get that information. That's really important information to have. And this has come up numerous times with me and Jody and the people that we've worked with. So I think what Jody was saying is really, really important.
I'm glad you jumped in, because my next question was going to be, how important is the care team to the care of a patient that is experiencing multiple myeloma? Did you want to add anything to that, Dr. McKenzie?
Yes, I do. I would be lost without the support in my office, because, the regimens that we use to treat the illness can be complicated. You might be coming into the office once a week, twice a week. You might be getting 3 or 4 different medications when you come in. Frequently, patients take a medication at home, and they need to have calendar help. So, the nurses, the medical assistants, the infusion nurses, the schedulers, everybody really has to work together to help navigate patients, especially when they're starting, when it's confusing. And I mean, this is a very good example of why the team, especially, the team up at my center and where Dr. Binder works, they're fabulous. And I, as a physician, could not do this without them.
Now, do you take into account, or do you pull into that team the patient's primary care physician, or have you now become the primary care physician for patients that are experiencing multiple myeloma?
I am not a primary care doctor. And I would not, I don't want patients to miss important things that their primary care doctor can help them with. So very frequently I'll know the primary care doctor, or I will, talk with them about what's going on. It's true that when a patient has multiple myeloma, they're seeing us more than they're seeing their primary care doctor. But it is really important that, the patients maintain the relationship with their primary provider. as much as we also communicate with them, you know, to just make sure that nothing's getting missed. Because even though I was trained in internal medicine, I don't practice that anymore. I practice hematology and oncology. So I do encourage my patients to make sure that they are staying with their primary as well.
Yeah, I think I agree. There's so many, and a lot of things that we give, a lot of medicines we give can make certain underlying other medical issues worse that the primary care doctor is already managing. So, for example, we give a lot of steroids for multiple myeloma, and if you have diabetes, your blood sugars can get very high. And so, working with your primary care doctor who already has that expertise about how to manage diabetes the best and already knows how to manage your diabetes is really integral. Similarly, some of the medicines can affect blood pressure and other things that were already chronic issues your primary care doctor may have already been managing, and just working together is so key.
It is a question. Is there any screening or preventive things that we can do to prevent the disease? And will having a genetic test help?
Yeah. So, as Dr. McKenzie has said, unfortunately, there's no good screening test for multiple myeloma. And, having everybody screen for some of these blood tests that we look for wouldn't really help because it wouldn't necessarily change, the long-term outcomes. Similarly, as she said before, I think the one thing that we do know is that there is an increased risk of developing multiple myeloma if you are overweight or obese. And so leading a healthy lifestyle, exercise, healthy eating, it's good for everything. It's good for heart disease. It's good for diabetes. And we know that exercise may help with some cancers, and there's some literature showing that being healthy and working out is very helpful. In terms of genetic testing, there's not a lot of knowledge about genetic testing for multiple myeloma or blood disorders in general. And there's a lot of research going into that now. Again, just another area where hopefully in the years to come, we're going to learn a lot more. There's a woman named Dr. Gobriel out of Dana-Farber in Boston who's trying to do a nationwide study enrolling over 50,000 people who have family members who have either MGUS or smoldering myeloma or multiple myeloma. And looking to see, can we find any genetic testing that may help? So in the future, we may be saying something different based on some of the research that's being done. But for right now, there's nothing that we can say.
Thank you. Thank you. Now, with us this evening, our special guest is Miss Dana Allen. How are you today?
I'm doing well. Thank you, friend. Thank you.
I'm going to ask if you could talk with us and let us know how things are as you navigate life while experiencing multiple myeloma.
Again, thank you all for having me. I got diagnosed 2021 for routine blood work. Tuesday, Thursday, I was in Dr. Bender's office. Like it was just that quick. Navigating through 2 transplants, some other clinical trials, and I'm on my last clinical trial, which is called TALV. And going through all of those other situations, I wish I didn't have to go through them to get to this one. This clinical trial is the one that it's very successful for me. From my understanding, there's not a lot of us that are on TALV. I'm one of the few. I think I'm probably one of 2 from the very beginning, Dr. Bender, if I'm not mistaken. I think I was on the top of that. And it has done very well for me. The side effects of it are side effects as everything else would be for any other medicines that we take. But you learn to adjust with them. This is something that I cannot change in my life, but it doesn't stop me from doing what I want to do, when I want to do it, and how it's going to be done. I wake up every morning as a grateful spirit anyway, prior to diagnosis, and it will not stop me. If I got to leave here, it won't be because of this. I'm going to keep going. I'm fortunate enough to have a team of Jody, Dr. Bender, Dr. McKenzie, who I just met today, and now you, Dr. Green. Very fortunate to have a team of experts that are willing to work with me during this process. Every day is a process. The bones hurt. They feel like concrete sometimes. I bruise easily. Sometimes my jaw hurts. Nothing majorly, Dr. Bender. Don't call me Dr. Bender and ask me what was I talking about the jaw thing. Dr. Bender, don't call me. But there are little things that I've noticed over time that have changed from the very beginning prior to 21. But whenever there's something that I notice that doesn't feel right, I will contact my team immediately. Jody, Dr. Bender, and they will respond with, hey, let's do this, let's get your MRI, and we go from there. There's never been a point where I've contacted my team and no one didn't have an answer for Dana. Everyone has been the most spectacular, caring, wonderful group of doctors and social workers ever. Jody, I've been with her since 2021, as well as Dr. Bender, have helped me tremendously with a lot of things. So when we talk about the social worker aspect of that, yes, she is a social worker, but she was so important of getting me to accept this, accept it, and know that there is help financially for me. I'll probably never be able to regain what I had before. However, with Jody's help and Dr. Bender and things of that sort, they have been able to just help me keep it all together. And I with having a dynamic team is so important. I'm just not Dana Allen. I'm just not number 1, 2, 3, 4. I am a part of the team, and they include me into trials that may come up or this and that and invites and things like that. I am included into what's coming up, what we're working on, what we're going to work on, and that makes everything feel so much better. So again, thank you all for having me.
Thank you for sharing. And one of the things they said that this is a disease that comes up in individuals primarily over age 65.
I am not nowhere near
Okay.
65. And if it's okay to say, I'll be 60 in November. I got diagnosed, Jody, what was it? 21, what was I, 55, 56, run about there somewhere. And again, it was just routine blood work. No symptoms, no signs, no nothing would have made me think, oh, something's wrong drastically. Nothing until the hematologist from Jefferson called me and said, we have to talk. And I went Tuesday, Thursday, I was in Dr. Bender's office. The process was just that fast. And we've all been together ever since 2021.
That you said your routine blood work, was this with your primary physician?
Because I used to work for Jefferson in New Jersey at Washington Township. So my primary was across the street. And I knew I'd ate had a lot of salt. I knew I wasn't eating healthy. I knew. As healthy as I thought I was, but I had a headache and I couldn't get rid of it. And I decided to say, hey, can you run my pressure for me? They ran the pressure, did some lab work. Then you got high blood pressure. I knew that. And with that routine blood work, it's how they found the myeloma. Is it a curse or a blessing? We'll leave it in the universe for that. However, with finding out, like I said, that Tuesday, Thursday, and I've been going strong ever since.
And I just want to say, there's certain patients that touch you along the way, and Dana has definitely been that. And she's all taught us lessons on living in the moment and being grateful. And despite whatever she's gone through, lots of hard treatments, she's always remained positive and optimistic and really living in the moment. And I think that one of the pieces of myeloma that is difficult is managing the uncertainty. And whatever comes up, she faces, and she has taught us all lessons on living. And Dana is also one of a nice program that we have at Jefferson is a buddy program where we match patients with a patient with a similar diagnosis and treatment. And Dana is one of our buddies, and she has touched a lot of our patients' lives as well and really been an excellent support for our patients. A lot of times people might have good support in their lives and friends and family, but really want to talk to someone who's lived it. And that's where the buddy program comes in. And Dana has been an excellent asset to that program. So thank you, Dana, for all you've done for
Thank you, Jody.
us.
Dr. McKenzie's
Yeah.
patient is one of the people that I met. And it was off as an off chance. We were sitting in the lobby at the old waiting room, and she was filling out paperwork. And I thought to myself, do you ask a person such a question? We're all in here for the same thing. So I said, we'll go for it. And I did. And Dr. McKenzie's patient is a very good friend of mine. We do a lot together in the city of Philadelphia with multiple myeloma, events, dinners, walks, and we're often together supporting each other. And we talk about how we feel all the time, her family, my family. And it is something that I think that we needed to find each other. And we did. And today we are still very, very good friends. And we need it. We need the support of one another.
Well, thanks for bringing
It's
up
helped
that.
my patient, I can say. It's helped my patient to have that support.
Jody, you mentioned the buddy program, and I'm grateful that it is beneficial and Dana is a part of that. Is the buddy program only for people experiencing multiple myeloma?
So our buddy program, it is, we train patients and caregivers. So we have caregiver buddies as well. So it's for all different diagnoses, and we try and match patients to people who have a similar diagnosis, similar treatment, similar age. So we try and really work with their families to see what they're looking for. And I mean, Dana could speak a little bit. And if we don't have an appropriate buddy, we will refer to, there are some other programs within the community as well that match patients with prior patients or treatments. So, but it's an excellent program. People have to go through training in order to really kind of be that support to patients. So, but we also do have caregiver buddies, which is really nice for the caregivers as well.
And how, if for the Jefferson patients, how would someone know about or find out about the buddy program?
So, I mean, we're also at Jefferson, we have the Cancer Support and Welcome Center. So we do have a brochure with all our different programs that come out for patients across the Jefferson community. Anyone can access them, and people outside of the Jefferson community can as well. But oftentimes the social workers or the medical team are talking to patients, and they will say that, oh, I'd really be interested in speaking to a patient. So we have a referral process of there's 3 different social workers who run the buddy program that help coordinate the program here at Jefferson.
Now, you mentioned the Welcome Center. That's the Cancer Center Welcome Center. What is that?
Yeah, so it's great. It's actually it's a program, it's a Cancer Support and Welcome Center where we have a lot of support programs and educational programs. We have a lot of things to really enhance patients coping and families coping through their diagnosis and survivorship. So we have yoga, Reiki, mindfulness meditation. We have classes on nutrition, symptom management, medical marijuana, whatever it can be. We have a monthly calendar that comes out, and we run a lot of different programs as well. They can be done in person or virtually. And patients who are seen at other sites can also access all of our programs. We do have a website with a central registration. It's called the Registration Hub that patients could register, and then you can see all the different programs that we have. And if people have difficulty with access, we can also help register patients for programs.
And what would be that website? Do you know it off heart that you could?
It's the SKCC Welcome Center that you can look up.
Okay, here's a question. Can either the physicians explain or let us know what the survival rate is, or if there is any documented information on survival rate for this particular type of cancer?
Um, so that at this point in time, we consider myeloma to be a chronic illness. It is not curable. Now that could change with newer treatments, but as it stands right now, we expect that patients will be on some kind of treatment, whether it's an active treatment with several drugs or maybe a maintenance treatment after a transplant. We usually try to keep patients on some kind of treatment throughout their lives. So, people can live for a long time with myeloma, but they will always have it. Dr. Binder, do you want to add anything to that?
No, I think that's right. Unfortunately, we haven't gotten to the point where we can say it is curable, but as Dr. McKenzie said, the medicines are getting better and better, and we're able to get people in remission and keep them there for many years, and keep them on medicine to kind of maintain that control. But it is always there, and unfortunately, it can come back, and many people, do die of multiple myeloma.
Thank you. Thank you. Now we're coming to the end, so I'm going to ask if everyone could give what your one takeaway message would be for today. And I'm going to start with the top of my screen. Ms. Dana, if you could tell us what would be your one takeaway message that you would like to share.
I'm going to say my takeaway is the fact that my care team recognizes that I want to do this and help someone else. I'm sure my name just wasn't random. I'm sure they thought long and hard. Do we really want Dana Allen? Yes, we do. I think that I'm willing to share personally the feeling of what this is. The takeaway is that I'm honest about it. I feel for those, unfortunately, that are just being diagnosed with it, because the ups and downs of this it can be horrible. It can take you places the mind that you don't know how to control that. So my takeaway is that I'm glad to be a part of this group, and the medical team, care team that we have up top here is spectacular. And thank you for having me and trusting.
Thank you for joining us.
Thank you.
Jody, if you could give us your takeaway for this evening.
Sure. So I think living with multiple myeloma does really impact people financially, emotionally, socially, and I think it's important to address the whole person, like I talked about. And I think it's important to ask and accept help, knowing that there is support available for you and through the trajectory of your whole illness. This is, it's a chronic illness as we've discussed today. And so really to endure that is really getting the support you need from your family, from your care team, and just whatever you can do, we're here to help address your needs. So don't be afraid to ask for help or accept help, and knowing that different feelings are normal, right? I worry more about the people that say they're fine, right? Because no one's really fine going through all of this, that you're going to experience a range of emotions because you're human. And so we want to be able to be there for you and help you through this process.
Thank you. Dr. McKenzie, what's your takeaway for the evening?
This is a tough one. I have a lot of takeaways, but something that Dana said earlier made me think of a comment that I've heard said before, is that, we can't always change the course of this disease. We can't always change the disease, but we as a care team, can help impact the way you experience it. So if you are sick, please reach out, see us, see a doctor, get it taken care of, because that's the way that we can help you. So it's we'd like to help you change the way you experience it if we can.
Thank you. And Dr. Bender.
Yeah, I think everyone says such good things. I feel like I can't match but yeah, I think the overall theme, the takeaway is that we're all in this together. It's not one person going through this, but we're there with you to do our best to help you through this process and make it as good as it can be, and help you to kind of get back to your life as much as you can. And we want that for you, and we do our best to do that. I will just add, since I was talking about clinical trials a lot, and something I just wanted to say at the end that I should have said before, is that, I did talk a lot about how important they are, but I think there's also a lot of skepticism around clinical trials out there, and this question of, experimentation and, um, is it really the best thing for that individual? And I'll just say that, each location, each cancer center, each spot, they have different trials available, with different drugs. Sometimes there's overlap, sometimes there's not. And the reason for that is because there's a lot of research out there. And there's a lot of opportunity to open different clinical trials. And each site, like Jefferson or Penn or Fox Chase, they're choosing out of many to open one or two. So if there's a clinical trial open at an individual place, at a doctor's office that you're being cared for, that doctor likely really believes in it and really feels that that's a good drug, or a good trial that's going to answer a really important question to further advance the care for multiple myeloma. It's not something that they're just opening on the side for fun. It's something because they really believe that they're helping to move the science forward and move the field forward, and I just think that's important to be aware of when thinking about clinical trials.
Thank you. Thank you, everyone, for sharing, for spending this time with us. If there's anyone who's looking to find a Jefferson physician, you can call 1-800-JEFF-NOW, and you can be connected with a physician at Jefferson. And I am thankful that you joined us for this conversation regarding multiple myeloma. Please, please, please visit the Cancer Center Facebook page so that you can see more information about other programs that we have. Visit the Welcome Center page so that you can find out information regarding programs that are available for patients that are experiencing cancer, not just multiple myeloma, but other types of cancer. And if you're looking to contact Dr. McKenzie or Dr. Bender, call 1-800-JEFF-NOW, ask the operator to connect you to their office. Again, on behalf of the Sidney Kimmel Comprehensive Cancer Center, thank you so much for joining us today. Have a good evening.
Thank you.